it's about what the FDA thinks when I think it comes to endpoints that matter. And we've got a little bit of a guide to move us through. And we have a variety of FDA approved endpoints, and they've been a little bit boring. We look at the, I call it docetaxel era, the more modern era, where we have overall survival prolonged beginning in 2004. And then in no quite particular order, I have looked at the OS, 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 OS. I can say that's Oliver Sartor up there. It could be my initials over and over again, but I don't think that's the case. Then you got a little RPFS, and as a co-primary. Chuck knows a little bit about that, having been PI on 302, the Prevail trials, and segmenting these groups into various sort of segments, if you will. One of these stands out as being a little bit different, and that's the apalutamide trial that was just approved by the FDA. And I thought we might drill down into that in some detail in order to understand what the reasoning is. And I've actually looked at it carefully, and so it's going to be a little boring. I'll talk about what they did with apalutamide. And it turns out that there's a history here. Like many things that the FDA does, it doesn't just appear out of nowhere. There was actually an ODAC back in September 2011 that began to look at radiographically detectable disease as a clinically relevant endpoint. And in this discussion, which was held as part of the regular ODAC, not as a configuration or part of any particular trial, but just a discussion point. Now, in fairness, they knew the denosumab trial was coming down the pike, but I think they wanted to kind of get ready for it, if you will. And what was stated in that 2011 ODAC is that people were looking for a substantial magnitude of improvement if you're going to be looking at an RPFS endpoint. And it needed to be done with a favorable risk-benefit ratio. So those were the two elements that were outlined at that time. And then there was an actual sort of test case, if you will. And that test case was in the ODAC February 2012, where ODAC was 11-1, if I remember the vote properly, said no to denosumab. There's not enough benefit, and there's not enough safety for us to be able to vote in a positive way. Now, there was no ODAC that was required for the apalutamide approval in February of 18, and it was the pivotal Spartan data. There clearly was a substantial MFS benefit. Will come back. That's metastasis-free survival, which actually translates plus with death as well, and a reasonable safety profile. And there's also a second trial with enzalutamide, which has a PDUFA date in July of 18. So we'll see how they respond to that. And this is not a new drug application, of course, like it was for apalutamide, which was an NDA, but this will be a supplementary filing for enzalutamide. So what are the elements of the trial design? It's not just the endpoint. There's more to it than that. And the restriction on the non-metastatic CRPC space, defined as being negative cat and bone, which is a little bit controversial as we move into a molecular imaging era. The inclusion of the PSA doubling time of less than 10 points as a clear inclusion criteria, yet it was quite fascinating to me that there was not a specific inclusion with regard to the FDA approval. So this was a little bit puzzling, and I'm going to dig into it more in a way that I have the opportunity to do. Randomization 2-to-1, stratifications, pretty typical here. Metastasis-free survival. A little bit interesting about how they did the endpoint. We've talked a lot in prostate about what we call prostate cancer working group 2 and 3. No, that was not the case. This was strict RECIST 1.1 with confirmation of a bone met in terms of a independent assessment using an MRI, CT, or some additional imaging. Secondary endpoints are very important. Time to metastases, which is a little bit different from MFS because this is metastases or death. Progression-free survival, symptomatic progression, which brought the patients into it. OS and time to chemotherapy, which could potentially be related to physician's choice. Adverse events, sort of as usual, I'll come back to that. And then I think Julie's going to touch on some of the patient-reported outcome data, the USFAC-P and the EQ5D 3-level testing. So the details MFS, randomization to distant metastases. They very specifically excluded pelvic nodes. It was a blinded independent radiologic review. This included death as well. A little bit disappointing in the New England Journal paper, they did not break out the deaths. They brought up the adverse event deaths, but not the other deaths. And that was a little bit surprising as well. I think thoughts should have been clarified. The additional conventional bone scans, and as mentioned, not the prostate cancer working group 2 criteria. Here's the substantial benefit. And this is a very unstable estimate of the apalutamide median. You know, they actually state with a median of over 40 months of randomization. When you look down at the number of patients actually out at this particular time point, you can see that the sort of fat part of the curve is way back here. So we should expect that upon additional follow-up that median is going to change. The placebo is pretty clean. You can see that these patients have gone ahead and really come off the trial as they've gone forward. So it turns out that this magnitude of difference with a hazard ratio of 0.228 is actually greater than 2 years. Very, very different than, 4 or 5 months with denosumab. The consistency of effect is seen in the forest plot. There was one particular group where the confidence intervals overlapped the 1, and that was African Americans for reasons that are certainly not very clear at all. As usual, African Americans are underrepresented in a disease which is overrepresented in prostate cancer deaths. It's an ongoing problem. Multiplicity of endpoints, time to metastasis, progression-free survival, symptomatic progression, all heading the right way with good p-values. Overall survival really was 0.7 on the hazard ratio. P-value is 0.07. I mean, that's pretty damn good. I mean, that's a strong trend, and I think that was influential as well. You certainly didn't want any of the survival going the wrong way, and clearly here it's going the right way, and it may even be potentially possible that upon the next look that this will have the opportunity to have an overall survival endpoint. Time to initiation of cytotoxic chemotherapy has ratio 0.44. There are a variety of exploratory endpoints, PSA response, 89.7 to 2, etc. And then here you see the PROs that are not really that much distinct. You have to realize these patients are asymptomatic because they just have a rising PSA, non-metastatic disease. The tangible patient benefit, I think, is seen here. A patient can report it. You know, one of the things when I'm looking at a paper, I love the scans. We love the PSAs. We love the biomarkers, but we love what patients say even more. And this is something that a patient could report. They say, I have had symptomatic progression. And to me, that's incredibly meaningful and would be something, if I were sitting at the FDA, I'd be paying a lot of attention to. And it's good. Hazard ratio is 0.45. So that's a tangible benefit. The SAEs in grade 4s were not hugely distinct. A little bit hard to see, but these are the SAEs 24 and 23. You have to realize that patients are on study longer with the drugs. You have to make an adjustment, and adjustments were made down here in the fine print. Nevertheless, there were some things that sort of came out. There were falls and fractures that were not previously appreciated with this drug, and it turns out that those were important, as well as the hypothyroidism that might have been there. So disclosure, I was chairman of the data monitoring committee, so I looked at this pretty carefully. We brought this to Janssen's attention and required a modification in the consent form, etc., as we were going through. This is a way of looking at adverse events that is unlike this. This is your traditional adverse events. What you see is what I call a chi-square analysis. Do you have it, yes or no? And it turns out that if you have a grade 3 event for 1 hour of one day, it's a grade 3. If you have a grade 3 event that is 24 hours a day, 365 days a year, it's a grade 3 event. I really sort of quibble with this. I don't think we communicate adverse events nearly as well as we should. So actually wrote a little editorial on this, and to my interest, what happened, there was a guy who had been working with Astellas who says, "Well, I know exactly what you're talking about, and here's what we're doing about it." And this was something called the burden of therapy. And here is an example. I don't think this is published. The fellow who developed it sent it to me. And what you can see is these are mild, moderate, severe with different classes of drugs, and really looking at the burden over time, which I think is immensely helpful in order to evaluate what your patients might anticipate. And then I had a little luck. This is Prevail. Now, I think most of the prostate people in the room know about the Prevail trial. And here is Prevail with all the toxicities from day 1 to 1,000. This has never been published. He sent it to me and said I could show it. So I am. But it's quite fascinating that you can see the adverse events as a function of time. Now, when he refers to grade 3, he has different definitions of grade 3 than what you're accustomed to. But nevertheless, you'll be able to look at the burden of the symptoms or the adverse events over time, not symptoms, but adverse events. And I think it is actually helpful to be able to view the data in this way. So in summary, Spartan, very MFS positive, greater than 2-year benefit, consistency of positive effect across multiple endpoints, clearly OS trending favorably, adverse events not noticeably distinct among SAEs or grade 3, 4s. That's something that was pointed out by the FDA. And for the pros, there was really no clearly detrimental functional impact. So, what else might we consider? Well, Chuck Ryan is sitting back there, and this is Chuck's data. So, Chuck, I'm going to give it for you. So, thank you very much. But I really liked it, because I like to think about how do patients feel, how do they function, how do they survive. Well, survive is easy, but feeling and functioning is not quite so easy. And so Chuck presented this in 2017 ASCO. He looked at unequivocal clinical progression, defined as cancer pain requiring chronic opioids. I think that was 7 consecutive days. Chuck, is that right? Yep, thank you. Deterioration to ECOG performance status 3. Immediate need to initiate chemotherapy, radiation, surgical intervention. So these are clinical judgments. This is something that a clinician and a patient can tell you about pretty readily. And when he looked at the reason for drug discontinuation, unequivocal clinical progression, and this is from COGA 302, which Chuck was the PI on, you can see 26% of the cases this was ongoing. Radiographic progression, only 30%. Now, I think we hold up radiographic progression-free survival in a little bit more respect than we actually should hold it up. Because when you look, there's a whole lot of other things that are ongoing. Others combined could be toxicity, it could be patient withdrawal consent. There are a variety of reasons why a patient can stop. That's 25%. With the UCP, 13% combined with the radiology, 30% radiology alone, and 26% here. So this is really important. And then Chuck did the right thing. He looked at the overall survival and the radiographic progression-free survival, which we think is important. We built all sorts of sort of models around it, is not as important when it comes to survival as this unequivocal clinical progression. And you can see here the p-value is 0.02, 27.7 versus 34.9 months. So I think that's pretty important, actually. The most interesting negative trial was also spoken to very specifically by the FDA. This is the ARMOR 3 SV, which was looked at with the ARV7. Now, the cool thing about this, this was approved by the FDA and in very particular meetings that allowed it to go forward with an RPFS endpoint. And this RPFS endpoint was actually subject to a lot of discussion, but key to the discussion was the restriction to the biomarker positive subset. Now, of course, they had to screen and screen and screen and screen in order to get that, and it's probably not feasible in this initial upfront setting to do so. But that's an interesting sort of give that when you gave the restrictive biomarker, you got the RPFS in return. And again, the DMC concluded that phase 3 would not meet its primary endpoint based on review of all the safety and efficacy data. This is a little bit complicated. I actually chair this data monitoring committee as well. But what you can see in truth, these patients were clinically deteriorating before the second bone scan could be performed, which was necessary to achieve the RECIST criteria. They were never going to hit the endpoint. It's too aggressive a disease when this E7. There was a specific discussion on the unequivocal clinical progression. The FDA did not go for it. They said we just don't know enough about it, and we worry about the consistency of effects. So, summary: new endpoints are now sort of being accepted by the FDA and CRPC. And by the way, we have trials like the Atlas trial that is going to be looking at initial metastases supported by IceCap and other data. I think that's a different setting than CRPC. But they're going to be looking at consistency of effects, magnitude of benefit, no detrimental effects on SAEs and the PROs. The grade of 3 for AEs will need to be considered. Clinically relevant endpoints are always in style. Consistency in measurement is a must. You have to figure out how to do this consistently. Alicia, you're going to help us. And the biomarker selection allows PFS role to become more prominent. And it's interesting to see how this is evolving because you showed John right at the beginning. I mean, how many approvals since? I mean, what's it? 18, 17? Yeah, I mean, I can't even count them all. I was going through mine. So estromustine was the first, and then there was strontium and samarium, and then mitoxantrone, of course, and then all of a sudden, 2004, the docetaxel started. Okay, enough said. I'm just kind of summarizing, I think, what the FDA is thinking about and how we need to think when we're going to design trials that are going to make a difference for our patients. So, thank you. Yeah.
The graphs you showed of adverse events over time, was that a single adverse event, some of the adverse events?
No. So what they did is they summed the adverse event by grade and would sum. So if they had a grade 1, 2, 3, they actually went up to I think 9 or something like that. The way that they graded the adverse events, and then they plotted them as a function of time. So it took those individual patients and tracked the percentages over time.
So a patient with 3 grade 3 adverse events is different than a patient with 1 grade 3 adverse event over time.
Yes.
In those representations.
It actually is, because if you had multiple events, then they combined it to create a higher grade. And that's sort of because if we take a regular, what I'm going to call the chi-square, the typical adverse event table we see, you can't see the overlap. But here they overlap them to create something more significant. If you had 2 grade 1s, then that became a higher level. Make sense? Yeah. I thought it was kind of cool. The guy was working with Astellas, and then he kind of formed a company a little bit around this, and he's trying to get it off the ground there. Anyway, he wrote me, posted a little editorial, and just said, "Hey, let me show you what we're doing." I thought it was cool, so I shared it. So
I have a question. So the non-metastatic CRPC trials now, in the era of advanced imaging like PSMA PETs, do we think this population may become irrelevant? Let's say a PSMA PET imaging gets approved, we'll detect metastatic disease sooner, and we may not have a lot of patients with biochemically recurrent, because a lot of these patients may have occult metastases, which we can't detect right now, and maybe detecting them better.
Well, the whole molecular imaging thing is going to affect the inclusion as well as endpoints. How we define metastasis is changing. I didn't really go into that because the FDA has yet to consider it, but absolutely positively, the way we're defining metastatic disease is different today than it was yesterday, and likely it'll be different yet again tomorrow.
The other thing, with regards to the unequivocal clinical progression is, I'm struck by how we do these trials and we talk about when to start somebody on a therapy and how to manage them, but we don't ever talk about how we should be discontinuing a therapy or declaring defeat or optimizing the long-term outcome in patients. The reality is most patients stopping abiraterone or enzalutamide today probably are stopping it for unequivocal clinical progression or PSA rise. That's one of two sort of points on that spectrum. But we just don't have any data on that.
Well, Chuck, you've been providing the data that's been guiding me, so I appreciate that. And I think that analysis on 302 is the best one I've ever seen. And
we never
say
published
that if you were in the room or out of the room. It's really nice to see the breakdown and how you manage to look at the RPFS as being only about 30% of the total.
Yeah, I think that's the key. Is that a lot of people were developing clinical progression, and I say this, when I teach about this disease, I say people progress within the lesions they already have frequently instead of developing new lesions. And 302 and the PFS endpoint was built around developing new lesions on bone scan.
Absolutely. So I concur, and thank you for your insights, and keep working.
Have you had any experience with health plans demanding or requiring a PSA doubling time of the 10-month cutoff for apalutamide?
I have not, and that may just be due to inexperience. It's just FDA approved. It takes a little while to get things moving, so I've not seen anything.
I've come across one health plan that's demanding that, but I can't see sitting in an office with Mr. Jones saying, well, we're going to have to wait 3, 4, 6 more months to know, whether you're going to be eligible for this drug.
It's interesting. Chuck mentioned a little bit earlier about the health systems and the cost, and of course we're involved in that. I'm on a new committee at Tulane University Hospital called the High Cost Drug Committee, and it's let's just say that the latitude that we've been able to operate with over the years is changing, and the healthcare plans are creating a variety of pushbacks, and I don't see it getting better. I see it getting worse, and pointing out that the FDA and the label was not true to the inclusion criteria, and I think that opens up a gap that could be problematic. Thank you, guys.